Well, thank you again for that invitation, that introduction. We're going to talk about spinal cord injury from sort of basic science to clinical management to clinical syndromes. I think, one of the scariest things when you're a resident, especially a junior resident taking care of patients that come through the ER, is being tasked with figuring out if someone has an injury, if they have a fracture, is it an unstable fracture? Does it need surgery? Do I need to call my attending, or can it wait till the morning? Those kind of things. So this chart just basically tells you sort of my personal experience with the surgical management of spinal cord injury. And you can see that there's sort of peaks and valleys to the levels for which people get spinal cord injuries. And the most common areas to see injuries are in the mid-cervical spine and at the thoracolumbar junction. And that just has a bit to do where people are susceptible to fracture dislocations in these areas. And we're not going to go into the details of fracture dislocations. That's a really another talk. But just to be cognizant about that. In terms of incidence, it's about 10,000 cases per year in the US, actually slightly going down over time, fortunately, because of preventative measures and educational measures. We see, for example, in Florida, much less diving accidents than we did before. The prevalence obviously is the incidence times the years that these people survive. And as survival has increased, the prevalence has increased. And it's an incredibly costly disease, not only to manage initially, but also to take care of the patients after their injury. And the cost is proportional to their level of injury. So obviously someone who's para is much less costly than someone who's quadriplegic, which is much less costly than someone who is quadriplegic and on a ventilator. In terms of mechanisms of injuries, most common motor vehicle accident, and these statistics are a little bit old. The motor vehicle accident as an etiology is declining, and that has to do with the fact that cars are much safer with airbags and seat belts. And we're still see lots of assaults, guns and knives, but we're also seeing more and more falls as cause for spinal cord injury, and particularly in the elderly with pre-existing stenosis. A relatively light injury can result in a significant injury to the cord because of the pre-existing stenosis. We're actually going to talk a little bit about that specifically. When you look at the pathophysiology of acute spinal cord injury, there are primary injury mechanisms and secondary injury mechanism. Primary injury mechanism is what happens at the time of the injury, and secondary injury mechanisms are the biochemical events that occur subsequently that can result in further injury and neurological deterioration. So the primary injury mechanism, acute compression, if like, for example, a fracture dislocation, all the way to shear or missile injury for a penetrating trauma. And when you look at a microscopic level, the secondary injury mechanisms are listed above. I'm not going to list every single one of them, but edema formation, vascular changes are important, electrolyte shifts, free radicals, and some of the secondary injury treatments or neuroprotective strategies sort of target these secondary injury mechanisms. When you look at the spinal cord grossly after injury, interestingly, that most cases, the spinal cord is in continuity in some way, either attached by axonal remnants or astrocytic remnants, scar tissue, or intact axons that are just simply non-functionally possibly demyelinated. So even in someone who's so-called complete, may still have neurological elements bridging the area of injury. And so that's an important point in terms of trying to identify possible treatments. The most common pathology is that of an area of central cystic necrosis or cystic degeneration. That's usually evolves from an area of central hemorrhage. And there may be a preservation of peripheral rim of white matter or pia. This is a autopsy specimen. And you can see here that there's a fracture dislocation. There's a central area of hemorrhage within the cord, but the cord is still in continuity. And this is sort of the most common thing that you see after spinal cord injury. You can also see cord maceration in more severe injuries, or cord laceration, for example, in a knife or a gunshot wound. And in some of the more minor injuries, like we'll be talking about the central cord injury, you'll just see some central softening with axonal disruption, but not necessarily anything more than that. And those are for some of the lighter injuries. If you look under the microscope, you'll see central hemorrhage, especially in the gray matter, necrosis, edema. You'll see axonal injury with retraction of the axonal ends. And if the axons are transected, you'll see organelle accumulation and swelling. You'll see myelin sheath injury, including demyelination, and inflammation, also very important, again, as a secondary injury target. A secondary injury sort of target for drugs, for example. The next important thing is the spinal cord injury neurological examination. And this is particularly important when you're trying to transmit a picture of how the patient is doing to your colleagues. And it also has a very important prognostic element to it. So it used to be called the Frankel scale. Then it became the Asia Impairment Scale. Now it's often referred to as the INSCI. They're all very similar, but they basically divide injuries into 5 types. Those that are complete with no motor or sensory function below the level of injury. B is incomplete with complete loss of motor function, but sensory preservation, including, again, examination of the perianal area to see if there's any preserved sacral function. That would be in B. A C is sensory incomplete and motor incomplete, but the motor function is less than 3 on 5. D is obviously a lesser form of injury, sensory incomplete, motor incomplete, but the motor function is greater than 4 on 5. And then E is normal. So that's the Asia Impairment Scale with regards to A, B, C, D, or E, but then there's also levels that you can define. And this is based on key motor groups that you examine. And so I'll give you an example, you can read the table here, but if somebody has no motor function in their hands and legs, but they have deltoid, biceps, and wrist extension that is greater than 3 on 5, then they would be Asia A C6. And then if they had wrist extension, but also had triceps that was greater than 3 on 5, they would be a C7. And the difference between a C6 and a C7 level is enormous. A C6 would be able to navigate an electric wheelchair, while a C7 could navigate a self-powered wheelchair. So you can see just one level, one muscle group can make an enormous difference in mobility. There's another term, 2 terms that you need to be aware of. One of them is spinal shock, and the other is neurogenic shock. Spinal shock refers to the motor sensory and reflex changes that happen early on after spinal cord injury. So for example, this is the easiest example and most impressive, is that when a patient comes in with a serious spinal cord injury and you examine their reflexes, they're often areflexic. So that, reflex hammer to the knee elicits no response. But if you see them in rehab 3 weeks later, they've recovered from the spinal reflex shock and they're hyperreflexic, have clonus spasticity. So that's an example of the early phases of spinal cord injury where the neurological exam may not be completely accurate. And it has to be distinguished from neurogenic shock, which is the cardiovascular effects of a spinal cord injury above T6. And essentially you knock out the sympathetic system and you have parasympathetic overdrive. So you have decreased blood pressure, which is the shock part, but you also have a decreased heart rate, as opposed to an increased heart rate where you might, which might be seen in anemic shock, septic shock, cardiogenic shock. So if you see someone with no movement and has a level above T6 and has hypotension and a bradycardia, that's a manifestation of neurogenic shock. And then there's a bunch of different spinal cord syndromes that you need to be aware of: anterior cord syndrome, central cord syndrome, and Brown-Séquard syndrome. And we'll talk a little bit about each of them. In terms of trauma, anterior cord syndrome is very rare, almost never seen. It's most common in discitis, where you get infarction of the anterior spinal artery and you have no motor sensory function below the level of injury, but you have retained dorsal column function. Unusual in trauma. Central cord syndrome, like I said, is super common, probably the most common spinal cord injury that we see. And we'll talk specifically about how those patients present in a second. And then Brown-Séquard syndrome is more common in penetrating trauma like knife injuries or gunshot wounds, where you get a hemisection of the cord. You'll have ipsilateral motor paralysis and contralateral loss of pinprick. And that's a Brown-Séquard syndrome, ipsilateral loss of dorsal column function. So ipsilateral loss of proprioception. And so we've talked about all of this. Anterior spinal cord syndrome is rare. Acute traumatic syndrome, spinal cord syndrome, super common. And what defines it is basically patients who present with severe hand weakness, greater than arm weakness or leg weakness. So they're paralyzed in their hands, but their leg power is pretty normal. It's pretty classic. Elderly patients, hyperextension injury with imbuckling of ligamentum flavum in an area of pre-existing stenosis. The sensory loss is typically incomplete, and patients tend to improve over time. So this picture is probably 65 years old. It was drawn by Netter, and almost everything in it is correct except for the bottom left figure. But again, older patient, hyperextension of the neck, has inbuckling of the ligamentum flavum, compression of the cord, weak hands, and strong legs. And the reason why it was called central cord syndrome, it was always thought because there's an area of central damage to the cord, that the corticospinal tract is somatotopically organized, and you're preferentially picking off the upper limb fibers while the lower limb fibers remain intact. And if you look at any textbook, Gray's Anatomy, Greenberg, the neurology textbooks, Harrison's internal medicine, all of them have this figure, which always drove me crazy. And I'll tell you why. So there's a bunch of syndromes in addition to central cord syndrome. Bell's cruciate paralysis is basically central cord syndrome with a patient who has an upper cervical cord injury. And it was described by Bell, but they present similarly with weak hands, strong legs. And it was also felt that the reason for this differential, presentation of arms and legs is that there was a decussation difference in the arm and leg fibers at the cervical medullary junction. We know that the corticospinal tract decussates at the medullary pyramids, and he hypothesized based on some old literature that they decussated at different levels, that you picked off the arm fibers, and that's why you got weak legs. So this leads to this here, and it's very timely because we just published this literally this weekend. It came out in Journal Neurosurgery as the front cover, and it's basically entitled a critical reappraisal of corticospinal tract somatotopy. And the gist of the paper is, and you'd have to read the paper to really sort of understand the reasons behind it, and we don't have enough time to go into the details, but it basically says that, you know, these pictures from Gray's Anatomy, Greenberg, and from Adams and Victor, which is the principal neurology text, is incorrect. There is no somatotopic organization in the corticospinal tract, even though there is for the spinothalamic and the dorsal columns, and that really the basis for the problems with hand function is that the corticospinal tract, which is uniquely human, and we need, you know, that there's major evolutionary differences in the corticospinal tract between a rat and a human, is predominantly important for hand function. And if you get a diffuse injury to the corticospinal tract, it will be manifest with weak hands. So that's basically the gist of the paper. And this figure is actually on the front cover of the Journal of Neurosurgery April issue. So the Brown-Séquard syndrome we've already talked about. There's also Conus medullaris syndrome, which is involving the conus of the spinal cord, where you get prominent autonomic dysfunction because of injury to the conus, so loss of bowel bladder dysfunction, and usually a combination of upper and lower motor neuron findings. That's a conus syndrome, as opposed to a Corticospinal syndrome, which is typically below L1, L2, and it's a pure peripheral nerve injury, so no hyperreflexia, only hyporeflexia, tends to be asymmetric, tends to have prominent autonomic dysfunction, and has a slightly better potential for recovery than a Conus syndrome. So that's really pathology, pathophysiology, presentations, clinical presentation syndromes. We're going to go now into the treatment strategies, which you can divide into medical, surgical, and experimental. And we'll start with medical. And so the premise for medical management is basically ABCs, airway, breathing, circulation. If you have someone who's hypotensive or hypoxic, you know, in addition to their spinal cord injury or their brain injury for that matter, things are going to go badly. You're going to promote secondary injury. We're going to talk about pharmacotherapy, mobilization, nutrition, DVT prophylaxis, and rehabilitation. And just keeping in mind that all of these treatments may or may have not undergone either phase 1, phase 2, or phase 3 studies to prove their efficacy. And we'll try to distinguish between those different types of studies in terms of the evidence for its use. So, you know, it was in 1990, so it's now 32 years since this paper was published, and it was a very impactful paper in the New England Journal of Medicine. It was impactful because it was a randomized controlled trial looking at methylprednisolone for acute spinal cord injury. You can see all of these luminaries in neurosurgery who were involved in the study, and particularly, you know, Wise Young and others who did a lot of the basic science work beforehand. And essentially, if you look at the study, it was a large study, spinal cord injury, multi-center, and it looked at methylprednisolone versus naloxone versus control, and found essentially that there was improvement with methylprednisolone at the doses listed here. But, you know, there were a lot of questions about the study, particularly things like the subgroup analysis that was showing efficacy. And I can go on and on of all the criticism. So we went through a phase where we gave methylprednisolone to everyone, and now we're in a phase where we give it to very few. And we do have guidelines, and the guidelines currently, and it could change, state that it's not recommended. And the reason why it's not recommended is that the evidence for complications is higher than the evidence for benefit. One of the real challenges in any spinal cord injury research is that patients without any treatment tend to improve. And this is a combination of a number of studies looking that if you're Asia A, that there's at least a 3 to 5% chance that you could change to an Asia D without any treatment. So the reason why that becomes difficult is that any treatment that you plan, you've got to understand that there'll be maybe a natural history of some recovery. So any drug or treatment that you suggest has to be better than the natural history. And again, this is a natural history chart showing how many people who are Asia A are ambulating after a year, how many with a B, and as you become less and less injured and more young, the chances of you recovering become higher. So if you're Asia C, less than 50 years of age, there's a 91% chance you'll be ambulating at the end of a year. So this is just, again, some comments about natural history. This is a table from that methylprednisolone study showing that it was a very small subgroup that showed benefit, not the entire group. And one of the big criticisms is that the 8-hour effect. So if they looked at the entire group of patients who were enrolled, there was no effect. They had to do a subgroup analysis of those who got treated less than 8 hours. And then these are the complications, which when you look grossly are not insignificant. Such things like wound infection, GI bleed, not significant, but you can see there seem to be considerably higher in the methylprednisolone group than in the controls. So this was the results of the NASCAS-2 study. But as I said, in the current 2013 guidelines, and I'm sure that 2023, they'll come up with another one, it's currently not recommended with level 1 evidence. Something that we've been working on in Miami for literally 15 years is cooling after spinal cord injury. And we have done a single center study for safety and then extended the inclusion criteria. And for the last 4 years, we've been doing a multi-center study with Jefferson, Grady, Barrows, Maryland Shock Trauma, looking at cooling for spinal cord injury compared to control. And again, without getting into too much detail, we published a number of articles in this area. There's a lot of different ways of cooling. We use a transvenous catheter that has a balloon at the end of it, which basically cools the blood as it rushes by. And that's a mechanism how we cool people to 33 degrees for 48 hours after their injury. And you can do MRIs with it. You can give IV fluids with it. And it's we use basically a Cool Guard catheter. And so this is like a typical patient who's been cooled. There's a 3-hour cooling period. We cool them for 48 hours, and then we slowly rewarm them. Essentially, this was an original study for safety on the first 14 patients. The Asia conversion rates were certainly favorable compared to natural history. Like I said, we increased our people who with cervical injuries to include Asia A's and B's, and now even more recently C's, and have published essentially 60 of our own patients who have been treated, and we're now up to about 60 patients who have been randomized in our larger prospective study. So again, we continue to work on that. There are other neuroprotective strategies that people are working on, including riluzole and others. In terms of surgical strategies, the purpose of surgery is numerous. One is to reduce the fracture, to decompress the spinal cord, and to stabilize the fracture with rods and screws, typically, if it's an unstable fracture. And the reason for decompression, it's been known for a long time in experimental animals that the injury severity is equal to the force of impact and the duration of compression. You can't control the force of impact, but you can control the duration of compression. So the shorter or quicker you decompress the cord, the better potential outcomes. And these are some of the animal studies that have been done over time showing that reduction or quicker decompression results in better outcomes in multiple animal models. Unfortunately, there's no prospective randomized studies looking at surgical decompression, but there is the STASCUS study, which was conducted by Failings and Vaccaro. And that basically looked at a multi-center study without randomization and looking at the outcomes of patients who got decompressed in less than 24 hours versus patients that got decompressed in greater than 24 hours. And this is how the study was conducted. This was the screen. These are the enrolled 313. 182 went to early surgery, 131 went to surgery, late surgery, and then they looked at the outcome of these 131 versus 91 patients. Again, remembering that this is non-randomized. And basically what they found is that patients who got treated early or less than 24 hours, and when you looked at 6-month Asia grade improvement, those that were decompressed early had significantly more 2-grade improvement in Asia score. So more patients went from A to C or B to D in the early group than in the late group. And that's shown here in one of the tables from the paper. So I would just say in general, based on these results and multiple other studies, that we tend to do early surgery on these patients, which means if someone comes in with a C6, C7 dislocation in the middle of the night, they usually have surgery in the middle of the night, even though you can criticize certain aspects of the study, but that's basically how we take care of things in Miami. And then the last part of the talk is really talking about how spinal cord injury really affects every single body system, from the heart to the lungs to the urinary tract to the GI tract. And we're just going to go over the various systems and the impacts of spinal cord injury on those systems. We talked a little bit already regarding cardiovascular, that patients can have neurogenic shock, they can have bradycardia, they may need atropine or a pacemaker to increase their heart rate. Very commonly, they come in hypotensive, and we often have to give them fluids or pressors. And, we have level 2 evidence to suggest that keeping the blood pressure map at 80 or greater can result in beneficial effects. So we often give them pressors for the first 5 to 7 days post-injury to improve outcomes. We do DVT prophylaxis. In fact, it is a requirement in patients with spinal cord injury because they're at such high risk of DVTs or PEs. And that's usually in in our center, Lovenox with anti-embolic stockings, and compression boots and early mobilizations. We tend not to do IVC filters, and we tend not to do heparin. The respiratory system can be severely affected because you can imagine if you're paralyzed and you can't use your intercostal muscles to help you breathe, And certainly if you have a very high cervical spinal cord injury that involves C234, or I'm sorry, C345, that you would infect your phrenic nerve function. So they often have pneumonia, atelectasis, ventilatory failure, trach. That's not uncommon, and respiratory therapy is an important part, and suctioning for mucus plugs is an important part to prevent them from getting on a ventilator or ultimately requiring a trach. If they're a high injury like C1, C2, and their phrenic nerve is not working, they'll often need a pacemaker. This is showing a patient on a road arrest bed, which we used to use more often than we do now, but it's a mechanism to improve pulmonary function and reduce pressure sores. The genitourinary system's not working. They have no spontaneous, or they have no voluntary contraction of their bladder, so they often require a Foley catheter initially. That's often changed to intermittent catheterizations when they're stable, they're suspect to urinary tract infections, and they can later on get autonomic dysreflexia, which is manifest by hypertension, sweating, headache, particularly when they get catheterized. They can have GI bleeds, something often referred to as a Cushing ulcer from the stress of the spinal cord injury. They often get H2 blockers, and they can have problems with alimentation. Occasionally, they'll need an NG tube or even peripheral or central hyperalimentation, but they do need to start a bowel program, which is often consists of laxatives and stool softeners. Again, because their GI system's not working, they're prone to contractures, pressure sores, heterotopic ossification, which is bony formation in their muscles that can be a source of fever early on. Again, preventing pressure sores is critical, and both the patient and the caretaker are important in that. And of course, this is psychologically devastating to the patient and the family. So we have psychology and psychiatry involved early for counseling. Often the patients will require antidepressants. The last thing I was going to talk about before I answered any questions was post-traumatic syringomyelia, which is something that we occasionally see after spinal cord injury, but it's important to recognize as a cause for secondary neurological deterioration. And so it happens in about 2 to 3% of cases. And so you can see, because spinal cord injury is relatively uncommon, syringomyelia or post-traumatic syringomyelia is not common. But again, if it happens, it's very important that you be aware of it. And I think there's a heightened awareness of it, and it's certainly easier to diagnose in the MRI era. And the pathophysiology is relatively simple. It's basically an injury to the cord with cyst formation. There's arachnoiditis around the cord. There's impaired CSF flow that happens. And because of that, CSF is driven into the cyst, and the cyst can expand. And the CSF often flows into the cyst through the Virchow-Robin spaces. As I said, MR is the diagnostic modality of choice, and we often do cine-MR, which can detect flow around the spinal cord using special sequences. The syrinx may go anywhere from 3 to 20 levels. This is evidence of a CSF flow study. I don't think the video will play, but you can actually look at the flow of fluid around the spinal cord with the alternating black and white lines, and that helps you detect where the blockage is. You can see here the syrinx is the white thing in the middle of the cord. And so how do we treat it? Sometimes we do shunting, but shunts, no matter which area that they empty to, can block, they can tether, they can become infected. So there's lots of potential problems with any type of shunting procedure. This is an example of a shunt autopsy specimen where there are literally 3 different shunts that have been placed within the spinal cord. And so the shunt failure rate, depending on who you read, is about 50%. Again, due to blockage of these shunts, they can tether the cord. This is an example of a tethered cord. So one potential way of treating it, if it's focal blockage, is basically untethering the spinal cord. And this was described by the late Bernard Williams. And that's simply untethering the cord and then often doing a duroplasty. And this is, again, an example of someone with a cyst of the cord where it was untethered and the CSF flow was reestablished. And that's shown in these sagittal and axial views pre and post-op. This is another example of someone who developed a syrinx 30 years after their initial injury. You can see a large cyst within the conus. This is an ultrasound that was done during surgery. This is opening the dura and seeing a lot of scar tissue around the Corticospinal and the conus. The scar tissue can be removed. You can see the syrinx in the cord, and you can fenestrate that cyst and also sometimes do a duroplasty. So that's all I got. That's about a 40-minute talk on spinal cord injury, and be delighted to answer any questions that people might have.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.